All right, thank you for sticking around for the raffle prize, I'm assuming, right? So, and those of you who were in the RPM session, I already apologize to you for hearing me for 2 hours talk now. So, but great to be here. Thank you, Wendy, for organizing this. Thanks you for first inviting us a couple of years ago to come and join this region and see what our expertise can do here, and then jointly develop over the time of what telehealth, what virtual care can really do in order to improve access to care, so that every resident has access to all the care they need, when they need it, where they need it, and all really means primary care, behavioral health, specialty care. You can read that vision statement on the postcards. If you are not involved in Thriving Together or want to learn more, if you want to take it to your ACH region, take a card, reach out to Wendy. And ultimately, it's about creating superb experiences for the patients and the providers. I mentioned yesterday morning, I was going to say last week, it feels like last week, that the needs of the patients are the only needs to be considered, right? The mission statement of the Mayo Clinic, or the needs of the patients come first. But what I discovered in my journey in healthcare is that in order to have the patients have a great experience, we need to empower the clinicians to practice on top of the license, to do the things that they do best 80% of the time. And that takes workflows, that takes great technology, that takes great data presentation, so that they can really fully live into the practice of medicine that they joined. So that's the goal here for the closing keynote. So I want to start with the end in mind here. And it's all about patient satisfaction. And patient satisfaction is enabled by clinician satisfaction. If you have a disgruntled or disappointed or disillusioned or burnt out clinician, no patient is ever going to have a really great experience, right? And most customer service organizations invest a lot in their staff in making sure that they have the tools and to do great customer service, and it's the same there. And this is built on systems and technology, right? We need to have the right information. The technology needs to work. So many physicians got burned out and frustrated, not because patients are complex or that. No, it's because all the administrative overhead and the technology doesn't work. And then I do telehealth with the patient, and then their phone points at the ceiling, and I can't hear them. And then there's the naked neighbor that runs through the background, and it's like, no, but that is not, sorry. There's one story that was told to me early in COVID. So, but that all then starts with leadership, right? As we know, excellence starts at the very top. Excellence starts with leadership, making a commitment to do that, to invest in the systems and the right technology, to create great clinician satisfaction, so that we can have patients and clinicians can have a great experience. And I think I should have used the lapel microphone. I may grab that microphone if I feel too constrained here at the podium. All right, so how do we create a superb experience? First, I want to build the case for virtual care. Then I want to talk about the anatomy of a bad experience. And then let's talk about how can we optimize the virtual care experience. You heard everything about me originally from Germany, came to the US 25 years ago, and then started at the Mayo Clinic, got my great introduction to healthcare. And with that, then I started Ingenium Digital Health Advisors, so that we could do the great work that we are allowed by Thriving Together to do in this region with these superb partners here from Renew and NCW Libraries and NCESD and everybody, and the center, so everybody's still here. So really great. Okay, so how do we create a superb virtual care experience? Let's start with definitions. I learned at way too many committee meetings at the Mayo Clinic that everybody agreed until somebody actually defined it. So here are our pragmatic definitions for telehealth. It is simply delivering care at a distance, and it's no more nor less. So I know CMS has a 3-page definition that has technology terms and everything in it, and telemedicine is practicing medicine at a distance. So for me, that's a subset. It's the actual interactions of the clinician with the patient. and then they'll become more obvious on the next slide. And then virtual care is providing care at a distance. Why virtual care? Because that's the term really that the media picked up in the wake of COVID. A lot of organizations or a lot of media coverage was around virtual care, and I've always liked that term. Early on, people said, well, virtual seems like it's not real, and so people didn't like it, but I think now it's common, so it's providing care at a distance. There is 9 common virtual care modalities that I just want to kind of put on your radar. Most of them you're familiar with, but you maybe never thought about that these are different modalities how we can deliver or provide care at a distance. At the core, obviously, are the audio, video televisits, and then there's telephonic care and remote audio and video exams. So the ability actually to do a remote exam, to look into the ear, to hear heart sounds, to hear lung sounds remotely. So there's tele-exam capabilities. This chart here goes from simple to complex, from synchronous modalities to asynchronous modalities. So the asynchronous modalities, what the last talk that I just gave was about periodic remote physiological monitoring, so blood pressure, scale, glucose, whatever you want, or even in behavioral health, activity level. Wouldn't it be great as a clinical provider, as a behavioral health provider, to know the activity level over the last week, right? Were you just stationary over the weekend, or were you active and out and about? Because that gives some insight. So there's some abilities even in behavioral health to use physiological monitoring. Then there's continuous remote physiological monitoring. That's more like continuous heart rate monitoring or continuous glucose monitoring. And then there's also patient-generated health data. Again, from a clinical provider perspective, wouldn't it be great if I can download your Fitbit data or your Apple Watch data and have it easily accessible the next time we see? That is technologically feasible, but it's complicated to set up to have that download and access to the information, but it provides a better picture. And for that is for me a modality of remote patient care or virtual care. Secure texting, I think we'll see much more of that, especially once we finally leave, hopefully, the fee-for-service environment behind us, and we're just about value-based care and how can we get patients engaged and activated in their care. And so having the ability to do secure messaging, either through patient portal or even through other secure messages is really great. We know of one concierge physician who has, where the patient have a secure messaging app on their phone, so they can secure message their provider if and when they need. And they don't have to log into a portal, look at the password that they had to change every 30 days, right? All the hurdles that IT likes to put into the way of great patient experience. Then the store and forward, right? Faxing and EKG is always my favorite example, is telehealth. So taking information, taking a picture of maybe your rash and then sending it and uploading it. That is more asynchronous and it's relatively easy to implement. And then the most complex and most asynchronous one that we are currently seeing is the whole world of digital therapeutics, right? The ability to prescribe an app. And there's a lot of apps around that are being validated or are validated in the behavioral health realm, and we're going to see more in others. In Germany, there's 2 apps that are currently approved and can be prescribed and actually get reimbursed. They're for free for the patients, and then the physician gets actually some nominal amount for prescribing it, and one is for tinnitus, the ear ringing. So there's an app that helps with the symptoms and the management. So again, digital therapeutics is the one that we will see more and more of. Again, we're still limited by our mindset of fee-for-service. And so once we get to a value-based environment where we really want to help the patients to have a great care, great outcomes, lower utilization, then we can employ some of those more advanced, shall we say, virtual care modalities. So yeah, virtual care is not just about video visits. That's a great starting point, but it can be so much more. And we have the technical advantages, but it's the great starting point because this is where we launch things, get our bearings, and then we can layer onto that with more complex cases afterwards. Shift happens. Glad I didn't misspell that word. 30 years ago, we had a revolution in finance, right? Everybody doing online banking, online payments. Now it's 24/7. Now there's almost no tellers. I go in my bank offices and it's like 80% empty, and there's like 3 people behind the counter said, "You really want to buy cash today?" So and then we have the e-commerce revolution, right? After the .com bust, right? But Amazon and Best Buy. You can buy anything online. You can have it delivered at home. You can have it delivered pickup. We don't even think about it anymore. And remember, this is only 10, 15 years ago. And then we had the communication revolution starting in 2007 with the iPhone. Facebook, Twitter, Snapchat, all these tools that we have now. So there has a lot of things been going on in our other lives, but healthcare kind of has not kept up with kind of these experiences that we have. And so, but as Dr. I think Shen was his last name, Christopher Shen from HCA was saying, there's a lot of innovators, right? If there's money to be had, if there's value to be found, then okay, let's have some venture capital money, let's invest $10 million, start up this company, see if it works, and if it doesn't work, yeah, then we shut it down and move on to something else, right? That's not what the business we're in, right? We're here for the patients. We want to have sustainable solutions that last. And so, but yet as a modern healthcare consumer, we really want four things, right? We still want quality care, and we want to have confidence that we are getting great care, and that's the intersection at which academic medical centers have lived for a long time. But also then came the whole conversation about value, especially in the late 2000s, early 2010s, right? And are we getting the best value for the care? And then we also want to have convenience, and that's the late 2000s. Here, the online clinics, the retail clinics. Do you remember the clinics in the grocery store? I think they've faded away now, or maybe there's some still around. But this convenience came from that shift that had happened because we have everything now on our fingertips. And I think we're at the statistics from Jason that the majority of urgent care, tele-urgent care, or maybe it was Matt Feynman, was about rashes. And yes, actually, that's the 2 telehealth visits that I had for my daughter was for rashes, because I don't need to have her come in, right? I took some pictures, I showed the pictures, so and we actually showed the rash on the camera, and it was just as good, and we got a prescription and it got better. So concierge medicine lists at that quality conference and intersection health systems. But really, the future healthcare leaders need to address everything, right? Especially the convenience piece, and I think it's the convenience piece that really telehealth virtual care brings, and it's also a value perspective, as Jason was saying in his keynote yesterday, right? The amount of time that it takes to drive, the amount of gas that it takes to drive. One of the first primary care physicians that we implemented telehealth for 12 years ago, she told me, she said, I just had this patient come in here. She's been a patient of mine for a long time, but I moved 30 miles north to the main clinic because I'm now the chief medical officer. And she came to see me and she said, yeah, I just, my grandson gave me a cell phone, and I didn't have gas money, so I sold my cell phone so I could fill some gas in the tank so I can see you, right? And I said, well, just wait 6 weeks and we have telehealth, and you could have just walked down the clinic and see me on the telehealth system, right? But that's the reality of what a lot of our patients are looking at. They don't have the transportation, they don't have the money, they can take the time off, they don't have daycare for the children. And so if we can offer them that additional convenience to get access to care, we can prevent an exacerbation of their condition. So convenience is really the element that is important. The data is actually very clear for again, the naysayers, right? The millennials actually say, yes, 83% said yes. I would do telehealth again if it was offered. So that was existing telehealth users asked the question, would you do telehealth again? And 5% said no, and 12% not sure. Baby boomers, 51 plus 33, 84% said yes or not sure. So only 1 in 6 said absolutely not, and the other ones were not quite sure, right? So actually that number is much higher than I would have expected, or some other people are saying, than Gen Z and Gen X. You see that here too. So that's data from now almost 2 years ago. So that is that's where the expectations are. It's like, yes, if I had a pretty decent experience, even during COVID, when we knew we weren't doing everything as well as we could have, patients still said, oh yeah, it's beneficial. So why, other than convenience, why do we also need to invest into virtual care? And one of the reasons was also mentioned by Dr. Chen and also by the keynote speaker yesterday, the last of the day. And it's what I call the digital health innovation avalanche. It's this slew of applications of digital health innovation that has been developed over the last 10 years, that has been clinically validated, that is venture capital funded, that it's making its way into the hands of modern healthcare consumers, not through necessarily the traditional route of our hospitals and clinics and behavioral health agencies, but through the Amazon Cares and the Apple Healths and the Fruit Streets and 90.3 and MD Live, right? All these other innovative organizations that are getting to care, especially largely driven by employer based care, right? Because employers have been complaining about, rightfully, about the rising cost of care to their employees and wanted to innovate the model, which is what drove Amazon into developing its Amazon Care program, which I'll come back to in a minute as well. Because Amazon Care, does it still exist? No. Amazon Care was shut down after 3 years. Was replaced by something else, right? They tried it out, it didn't work. Okay, moving on. Try that with a hospital, right? Let's open a hospital and let's open it. It's not financially sustainable, so let's move out again. Now, in a virtual environment, you can do that because it's a low cost to entry, low barrier to entry, right? But in the brick and mortar world that we're still going to be in and still have to be in, it's not possible. And that's why we, as the traditional healthcare system, as I would like to call it, need to get better at embracing digital health innovation so we can use it in the right way and long-term and sustainably. And that's the number that I think Ryan was his name, that the keynote speaker last night was trying to come up with. And it's been $100 billion invested by venture capitalists into digital health innovation. And you see the number there, $30 billion in 2021, $15 billion in 2022, and in the first half, $6 billion. So that's $50 billion just in the last 2.5 years of venture capitalists thinking you can come up with a solution that can improve healthcare and health outcomes and that can make money. And that has clinical validity, but also financial validity. And that is the competition we're against, but as we also know, that is not necessarily continuity of care and care coordination. It's isolated solutions, looking at the most lucrative, most healthy patients in our communities to that cash pay or they're well insured, but that is only a fraction. So, the problem in healthcare, from my perspective, is not the lack of innovation, right? There's enough innovation out there. It's that we have a very slow pace of innovation adoption. And why? Well, you all who are providing healthcare are really good at running healthcare delivery services, running operations, running healthcare. How many new services or new innovative things have you done in the last 20 years, right? It's not 50 things, it may be 3 things. It may be a new EHR, which didn't feel innovative at the time before or after, felt painful. So you don't have the DNA, the history of innovation. Amazon, is Amazon innovative? I mean, they have innovated from day one. I mean, they were a different company 3 weeks after they founded, and then different company 3 months, and then 3 years, and 30 years later, they're a different company still. So their DNA is innovation. And so we really need to bring innovation into healthcare. And this is what this program that Wendy has put together here, right? That's what Thriving Together has funded with this, is to bring this idea of innovation into the organizations. As Dell was mentioning in the initial keynote, right? The investment in the infrastructure of the telehealth optimization to build the baseline now allows them to launch a telehealth service in a jail in a matter of 2 weeks and have the confidence and audaciousness to say, yeah, I think we can pull this off, because he's got the trust, because the people are involved and the processes are defined and the technology has been validated, right? And that now this organization is set up to constantly adopt innovation and to think about it. And I know Dell has some other ideas up his sleeve that are even bigger for next year that work on innovation. But it is that, right? But that's the knowledge that this Thriving Together program really has enabled to bring out into the communities, to think about, oh, we need to be in a constant mode of launching new services, new modalities, new things, digital therapeutics, right? Continuous glucose monitoring, RPM. This is going to be the standard, right? One of the Mayer brothers said in 1932, the only constant is change. He quoted one of the old philosophers, but was really what he brought to the Mayo Clinic. It's like, that is the only constant. It's always going to change. And we've seen change in reimbursement, lower. We've seen change in staffing availability, lower. So that's changes as well. But let's create more positive change, more innovative change here. Because the competition is there, right? There's the MWells and Teladocs and MD Lives. There's the CVSs and MinuteClinics and Walgreens that are getting into telehealth and telehealth provision. There's Walmart Health. There's Amazon Care. I'll take it away in a minute. There's Best Buy Health. And there's also Dollar General. We're working with an FQHC who has 5 locations. And guess what's within 1 mile of each of the clinics? A Dollar General. And it's ubiquitous out there where they are. And Dollar General just made the announcement, yeah, we want to get into telehealth. So right, we've created a vegetable oasis around the nation. Now we want to create health. No, okay. This actually didn't come to anything, but I still have it in here because it was the Cleveland Clinic teaming up with MWell, forming the clinic. That was shortly before and shortly after Matt Feynman left the Cleveland Clinic. So, but that's also right. We get the large academic medical centers now getting collaborating with these digital innovators, and the reason why it didn't work is because there's a culture clash, right? Because the way that Amwell constantly innovated itself is different than how the Cleveland Clinic operates, even though they're very. And then here are names that you probably have never heard of, and there are companies with millions or hundreds of millions of dollars in revenue providing virtual care offerings. PlushCare, Sesame, MeMD, Virtual Well, HealthTap, Doctor on Demand, right? They are out there and they have patients that are enrolled, and so that is the challenge that we're up against. And then and Amazon just replaced itself with One Medical, but now you go to Amazon.health, and as a Prime subscriber, you get access to free virtual care as part of your Amazon Prime subscription. So, right, and it's for one-off urgent care things. But wouldn't it be nice if my primary care physician would know that I just seen Amazon Care 3 times over the last year, so that they know what's going on with me and don't prescribe me something or don't address something that I forgot to mention. So that is really the challenge. Just to give you a visual here, like here are some 150 digital health companies. That's the slide from 2021. And it's just amazing, right? That's what $100 billion will get you, and it's just a subset of digital front door or digital pharmacy, care coordination, workflow digitalization, home health tech, billing and payments, clinical intelligence, provider directory. So it's not about just all care delivery, right? It's all the other auxiliary digital health as well. But there's plenty of applications around. A lot of you in the here in the audience are in mental health. Here are representative mental health startups by category, right? Digital therapeutics and measurement and testing, non-tech and others, peer-to-peer, telehealth, mental wellness, right? There's all this digital health innovation that is going on, and that it's being deployed and that's being funded and promoted and marketed. And then also validated in clinical trials as well as they kind of look at those systems. So the case for virtual care is we have the expectations of the modern healthcare consumer. We have the competitive pressure of the innovative startups and non-traditional competitors that are really good at constant innovation and that have the luxury of just shutting something down. Oh, this just lost $100 million. Yeah, then we shut it down, right? We cannot afford a hospital or health system to lose $100 million. And then the growing efficacy of virtual care and digital health, we've demonstrated it with COVID. We probably wouldn't have had this conference if it wasn't for COVID, right? We wouldn't have convened that many people engaged and enthusiastic about virtual care. And then virtual care and digital health can also be used as a recruitment tool. You may recognize those different pillars here on the right. They're kind of mimicking the kind of organizational strategy that Dell had laid out, right, for the people and the community. So what I'm saying is here that virtual care helps you to achieve your overall organizational objectives, right? So to provide great service to your patients, to be financially sustainable, to have quality care and to fund growth in your area and to be there for your people. Because young people getting into healthcare, they know that virtual care is the modality of the future. So they want an opportunity to work for an organization that embraces this innovation. So here is the slide for the CEO to put the weight behind why should we invest in virtual care, because it's multifold. Okay, so that was the case for virtual care. So let's look at the anatomy of a bad experience, or actually, in order, as I mentioned at the beginning, to create happy patients, we need to have happy clinicians. We need to invest our resources and our time to make sure that the clinicians have the tools they need to do their job well, have technology that doesn't frustrate, have workflows that allow them to practice on top of the license. So why are clinicians apprehensive about telehealth? I've discovered or seen kind of 8 different reasons, and so here are the ones that I've encountered, especially if you think about it in the wake of COVID. The first thing that I've discovered and saw was that a lot of clinicians who were thrown into telehealth, saying, here's a Zoom license and a webcam, now do telehealth, had a sense of loss of control. Right? They felt like a fish out of water. It's like, I don't know what to do. I don't know how to direct the patients. I don't know how to engage the patients differently. We had a conversation with some tele-speech pathologist earlier, and she said it's a very different skill sets to do tele-speech pathology than to do in-person speech pathology. I need to use different skills and different tools, and I have some tools available electronically, right? So it's a different mindset. And clinicians, from my perspective, from what I've learned in working with them, they are trained from day one to be competent and to be confident in their decision-making ability, right? Patient presents with some situation, you cannot say, well, let me think about what you have. I think I read a research article, give me 5 minutes, I'm gonna research, right? No, you have to have confidence, like, okay, this is what we're gonna do, here's our care plan, I want you to have this exam, I want you to get this medication or get this blood test drawn, right? So you need to exude confidence, and you're very comfortable in your exam room or in your behavioral health office, but over video, when you didn't have control over what the patient was doing, is somebody with them, we didn't have all the protocols and things in place, and so that's where a lot of clinicians were really apprehensive about it, because they were no longer in control like they were in the exam room. Nobody wants to look stupid, and especially not clinicians, right? I don't want to fumble with the technology. I don't want to press the wrong button, or it's like, okay, right? So we have a concierge physician that I mentioned earlier, right? And he always said, well, okay, I may lose you now, because last time I did this, right, the connection dropped, and then, but I'll be right back, right? So, but that is sad, right? And clinicians shouldn't have to deal with that, right? They should just go, click a button, and the patient is there. They have a conversation, and then click a button, and the patient is gone, right? That's how it should be. It should be like that, and that requires workflow and technology. They had bad experiences during COVID, a variety of reasons, and now going back to the deeper reasons, they also want evidence that it works, right? Well, a lot of the questions before COVID and not so during COVID was, well, does it work? Is it efficacious? Can I really do anything? Which is one of the reasons why we brought Matt Feynman here to talk about, yeah, you can do virtual exams, you can do a lot of remote exams, you can do a lot of things. And then Jason talked about the data now that we have that shows, it's just as efficacious, maybe even cheaper, but it's no worse than in-person care, right? But that evidence was not available. And they don't think it's good medicine, mostly because that's what they were never trained about how to do this properly, and never had any website manners training, or what do you do in this scenario. Also, sometimes it's this mindset, okay, it's either I do virtual care or I do in person. No, you can do both. You can do virtual care, and you can say, I don't think I can assess you accurately over the video. I would like you to come in tomorrow, right? So, but then our fee-for-service system says, well, you can't bill twice for the same visit in a 24-hour period, or some other regulations that are standing in the way of doing that. And they assume patients don't like it, don't want it. The data that I showed earlier, I think, shows to the contrary, and sometimes that's a red herring, that's a projection. I have found so many seniors who are just delighted and proud that they were able to do telehealth, that they didn't have to call up their grandson and say, hey, can you drive me again to the doctor? And I know last time it took 3 hours. I'm really sorry. I know you have a girlfriend you want to be with. No, right? They don't have this, they have autonomy. right? And they're so proud. It's like, oh, I had a telehealth visit with my doctor. That was very nice. Well, I clicked the wrong button, but the nice lady on the other side helped me to unmute myself again, right? So, and so patients, once they get trained in how to do it properly, then why wouldn't they not want it? And if they don't want it, then they still can come in. They were concerned about reimbursement. We've talked to that ad nauseum here. And even before COVID, there was so much reimbursement for telehealth at parity that people didn't even know about. But they made the assumption that it's not paid, or heard some horror stories where it's not paid at parity. And there were some exemptions to that. But for the most part, Medicare did pay for telehealth, not to the patient's home, but from clinic to clinic and other scenarios. And actually, a lot of private payers even paid for telehealth to the patient's home prior to COVID. A lot of people don't know that. And then they were also concerned about malpractice claims. One of our team members is an MD turned JD, and so I keep in touch with him. And so, there has yet to be a real big any malpractice claim around specifically to telehealth or telemedicine. There were some early on about prescription of drugs that were not good. But overall, you can deliver great care about it. So what do we do about it? Sense of loss of control, co-design the workflows, right? Just sit down with a clinician. It's like, what would an ideal Happy Day scenario workflow look for you like? What is the ideal experience, how you would do that? How about you see your appointment on the schedule, you click on the link, you're in the waiting room, it tells you that the patient is in the waiting room, you let the patient in, you introduce yourself, talk to the patient, and then you click the red button to hang up. Would that be a good experience? And I say, well, that sounds pretty good. Yeah, okay, let's go create that. Or they have some other ideas, or they have some other things. But very few clinicians got involved in the design of the workflow or the experience, and it does not even get asked. Don't want to look stupid? Well, just give them some knowledge, right? Here's a little training on Zoom and all the different features and what the different buttons means, or on whatever technology you're using. Here's the workflow we're implementing. Here's the policies we have put in place. Here's a 20-minute training on website manners. Look into the camera, establish some rapport, saying, hey, is this your first time doing telehealth, or have you done this before, right? There's a few tricks. We do a 20-minute training on that, and it does wonders for the confidence of the clinicians. And then also how to do virtual exams. Bad experience during COVID, if that comes up, just get together with a clinician and have a post-traumatic stress disorder intervention. And just talk about, well, what was really bad? What was bad about it? Oh, the patients didn't know how to use it. Okay, we now have a telehealth tech check process by which we call a new patient and we say, hey, do you have a few minutes for your first telehealth visit? I want to walk you through whether you can receive the link and walk you through these steps. Oh, that's great. So that the patient does not show up unprepared, right? Just like we prep a patient when we're rooming them in the in-person environment. It's just that the prepping here happens here at a distance, and it can happen 3 days before, or it can even happen in the half hour before. They want evidence that it works, share the trials, research surveys, and also facilitate physician-to-physician or clinician-to-clinician conversations of those who are doing telehealth, so that you have a peer-to-peer conversation about what works. They don't think it's good medicine. Just change the mindset, or just emphasize that telehealth is a clinical tool. It's a tool that you have as a clinician to decide whether this is the right way to use. Now, the patient may request a telehealth, but then it may not be the right condition, right? Especially in behavioral health. There may be some patients that would be better if they were to come in. And you as a clinician should have that decision-making ability, whether you can see them over telehealth or not. So really so it's not just, hey, as an organization, we're doing telehealth and now everything has to be telehealth. No, it's a clinical tool that you can use to ensure continuity of care or even care coordination. And then also point out that by meeting with the patient on a regular basis, you increase kind of that patient engagement. Assume patients don't like it? Well, let's ask the patients. Let's do a survey, or let's share those national surveys. Well, if the national surveys don't apply to the residents of Okanagan and Chelan County, then let's do a survey here, right? So, concern about reimbursement, just share the data about reimbursement, share the data about policies, and then malpractice claims, similar thing. find some reports that talk about that, if that is a question that comes up. So those are some tactics you can do if you run into some resistance with your clinicians, that they're apprehensive about it, and so some tools about that. All right, so how do we optimize the virtual care experience now for the clinicians as well as for the patients? Darwin said it's not the strongest of the species that survives, nor the most intelligent that survives. It's the one that is most adaptable to change. And we are in a time of rapid change and have been for a while, but especially change in the way that we can deliver care, that we can care for our patients and be in touch and impact their health sustainably and efficaciously, so that they, especially the ones with multiple chronic diseases, so that they can have a great quality of life and not don't need to be in the health system. And so our mindset here around change is around change management. And one of the tools that we've been using is called the ADKAR model. It was developed by the ProSci Institute, and it stands for, it's an acronym of 5 different steps. The first steps is awareness and desire. In order to affect change, you need to raise awareness of why you're doing this, and then you need to create the desire in the people to change. So clinicians need to know, why are we doing telehealth? Why is it important? Why do we invest in it more? And then create the desire in it and find out what is there. Then you need to provide the knowledge and the ability to do it. And then you need to provide reinforcement, trust but verify. Just to build, just roll it out and hope that it works. Usually does not work. You need to have some data collection. You need to have some measurements in place, so that you can make sure that people don't go back to the old ways. And so when you have those 5 things in place, then you get change. What I love about this model is, like, if you take one element away, you end up with a certain reaction or emotion. If you take awareness away, you get confusion. It's like, why are we doing this? If there's no desire, then yes, you get resistance, and so you just need to find the desire. And then some clinicians talked with one of the clinical providers yesterday, and she said, "Oh yeah, there's one clinic, and the physician is against it, it's old school, and the PAs are against it." And I said, "Well, don't start there, right? Maybe create the desire with competitive pressure, where all the other clinics are doing telehealth really well, right? So find the desire." If there's no knowledge, then there's reluctance, right? People don't want to look stupid. I don't know where to find this. I don't know where to get help if something breaks, right? Or if I don't have the ability to do it, then there's frustration, right? I click this button and it doesn't work, and I don't know why, and the patient is not here. I just had him on the screen and now he's gone, and right? So we don't need our clinicians to deal with that. And then if there's no reinforcement, then there's backsliding. So, and now's the time to take a selfie or just a screenshot. Okay, I'll wait for a second. And the presentation slides are on in the handout as well. And if you go to our website, just Google ADKAR and or search ADKAR on our website. I've got a couple articles on that as well. All right, so let's break this down. I've commented on it a little bit. So how do we provide the knowledge and the ability? The first one is kind of what we call the website manners training. So bedside manners, right, and then website manners, which my spell check always wants to change to website with a T, but we're meaning website manners. So the first is, the idea is to increase clinician confidence and comfort, and improve the clinician's regard, and so that they have a high satisfaction. Also, we want to make sure that the privacy of the patient is maintained, right? That's why part of the protocol is, are you alone in your room, or is there somebody with you, right? That's a standard question you need to have clinicians ask in a telehealth visit. Okay, I see you on headphones, so nobody can hear me, but who can overhear you, right? Because you don't know what's going on in the environment. It puts the patients more at ease when clinicians have mastered video care, higher patient engagement, which then leads to improved continuity of care and improved health outcomes, right? Because if patients are engaged in their visit, because the physician felt confident in their ability to do it over video, then the patients will be more engaged. So enabling clinicians to practice on top of the license, what I mean by that is not the discussion about advanced practice providers and clinicians. What I mean here is that doing only the things that only they can do, right? Can we optimize our health system in the way that our healthcare delivery processes in a way that clinicians can really practice on top of the license, that they only do the things that only they can do, and everything else is taken care of by MAs or by nurses or by schedulers or by tech people or whoever it is, right? Because we have a clinician shortage, and so we need to optimize the capacity. And I know from talking to clinicians that when they do 89% of just practice in medicine, they're actually, even though they're working hard, they're still pretty satisfied, because that's what they went into the profession for to begin with, is to take care of patients, not to fill out paperwork or attend committee meetings or all the other overhead. So it's really about workflows, training, and support. Here are my favorite friends, the 7 dwarfs, the telehealth workflows. Little play on words if you can read the red signs. So the first one is telehealth visit. The point of this slide is to, when you think about what is the workflow for telehealth, there is not just one workflow. There are 7 different workflows. And very few organizations, if any, really redesigned all the 7 workflows for the virtual care experience. And so obviously the telehealth visit, yeah, that's straightforward. Everybody did that. Okay, you click on a link, waiting room, you have a conversation. Okay, that was pretty straightforward. But what about telehealth scheduling, right? So you need to ask the patient, well, what technology do you have? Can you receive a text? Do you have an email address? Are you registered at our portal? Do you have a smartphone? Do you have a tablet? Do you have a laptop? Are you going to be in a quiet environment? Don't be driving while you're on the video. Don't take us to the bathroom, right? So all those things, right, have to be addressed during scheduling that you don't do in an in-person environment. Post-visit, right? I have had a few telehealth visits, and the track record is not great, right? I have the visit, and then the visit ends, and then there's no follow-up. Nobody calls me, nobody emails me, right? I tried to call them, I was on hold for 5 minutes, and so because in an in-person environment, I walk out the office and there's a big stop sign that says stop at the desk before you leave the building, right? Pay your bills or schedule your next appointment or get a referral form or order your blood test, whatever. So there needs to be a handoff process to be identified. And I'm thinking mostly about primary care here, not so much about behavioral health or specialty care then. And then there needs to be a follow-up. How do we follow up with the patient a few weeks after? Is that what is different here in a telehealth environment? And then there's telehealth billing. Obviously, we needed, the billing departments needed to learn a lot about the codes and about the coding and about the GT modifiers and 95 location codes and all this craziness that was going on the last 3 years. So need to identify how you bill for telehealth and who can you bill and who can you not bill and where are you at parity and where are you not at parity. Then there's also the rooming process, right? Very few organizations have a great rooming process, right? My ideal rooming process is I get in the waiting room and then the nurse appears and they ask me for my chief complaint. Do I have a blood pressure cuff? Do I have a blood pressure measurement? Do I have my latest weight? Right? They can do that and then say, okay, see the doctor 7 minutes ahead, so I'll put you back into the waiting room. You could just check your email or do whatever you want, and then he'll be on the screen shortly. Right? So that would be a great televisit experience. Very few organizations have actually implemented that. And that's when we don't get kind of vital signs or chief complaints in there. We can also do it by filling out an online form. That's another way to do a telehealth rooming. But again, that's another workflow. And then the last one, the 7th one here, is what I call telehealth onboarding. And I referenced that, and I think it'll come up here in a minute, about a tech check. So the ability to actually help a patient for the first time to get set up on the telehealth system to validate that they know what they need to be doing. So those are the 7 workflows that you need to identify and define, and only one of them really affects the clinician. They need to know how the patient is roomed, then the telehealth visit, and then what happens afterwards. So clinician training breaks down into workflow and technology training, how to use the technology, how do you document it, and how do you code it, so they need to be trained on that. Especially if you're the documentation for the virtual exams, as Dr. Feynman was saying yesterday. Then a training on the website manners, look into the camera. I do a lot of these webinars, so I'm always looking into the camera now. And right, so look into the camera, make this eye contact, this virtual eye contact, even though it feels disconnected, but it really has a great effect. Virtual exam training, and those are the 4 areas of training. And so, actually breaking this down. And this is the time investment that we allocate for this amount of training. So the first one is telehealth awareness training. That's, okay, why are we doing virtual care? Why are we doing telehealth? Here's the workflow. Here's how this works. When a patient is going to be in a waiting room, here's how you click it. Here's how you use the technology. So that's kind of combined. Website manners, and that comes up here in a minute, and then virtual exams, really talking through what can we do and have some discussions. Other conversations to be had is developing clinical guidelines. We just worked with a number of clinical providers at an FQHC to develop their clinical guidelines as to for same-day ad hoc visits. So when is telehealth appropriate, when is telehealth not appropriate, when does it first get triaged by the nurse before they make a decision, when do we send them to 911, to the emergency room. So yeah, 1.5 hours is all it really takes to make clinicians confident in their ability to do telehealth well. Website manners, eye contact for 30 seconds at the beginning, acknowledge any background, like I think we had a conversation yesterday with somebody who was saying they had a shared office, and so they were just saying, oh yeah, there's somebody else in the office here, do you mind? And if the patient minded, so you just acknowledge that there's noises, that it's new, and hey, isn't it great that you didn't have to come here? I just saw you yesterday, I just wanted to go over the test results with you, so glad you didn't have to make the 90-minute drive down or the 30-minute drive down, right? So ensure that the patient has comfort, that there's privacy. Make sure that the clinician background is professional, that the camera is positioned greatly, not like that, because now you're a member of the witness protection program, and you may have to look elsewhere. And this is not my chocolate side here, as we say in German. That's not my good side. What great physicians do is said, okay, if I'm looking here over this, I'm looking at your medical record, and I'm just going to enter some information. I'm not ignoring you, right? I'm not watching a YouTube video. I'm just, right? I'm just, right? And then they look back into the camera where the person is. So oftentimes we set up with 2 monitor systems. So you just acknowledge it, and then body language, right? You can lean into the camera, you can lean back, you can use hand gestures, you can share your screen and other things. But that's really the website manners training that we do. We did that in the wake of COVID with 15 primary care clinicians in an FQHC, and they had a great experience doing telehealth in the following week. There were 10 clinicians that didn't want to do the training, that didn't like telehealth, and predictably, self-fulfilling prophecy, they had a bad experience doing telehealth. But the physicians who got that training, even though they were apprehensive, they had more comfort doing that. And we did that basically in the morning. We had two 1-hour sessions with the clinicians going through the website manners training and the workflows and the technology. So it's a very, and then periodic eye contact, train yourself to look into that webcam, even though it feels weird. But if you're making a point, if you really want to emphasize something or be emphatic, then you can do that. This is the list from Matt's presentation, right? You don't need to do all 10 steps here, but these are the things that you can document. And again, it's critical that you sit down with the clinicians and with your coding department to see, okay, what do we need to code when we do want to document a virtual exam or a physician-directed patient self-exam. How do you document that into your record? Good, and then the other thing is you need to provide support for the clinician. As I said at the beginning, leadership, transformation, change starts at the very top. And so having leadership involved, like Dell's organization has a telehealth steering team now that meets on a regular basis to just look at these different scenarios. And it's representation from different clinical services, from IT, from leadership. And so really having that support, having a telehealth support team, again, doesn't have to be full-time, but somebody who is knowledgeable about the workflows, knowledgeable about the technology, and then there's the kind of operational support team with the technology or financial questions or billing questions. So just identifying resources within your organization, no matter how small your organization is, who are the go-to persons so that clinicians feel supported doing that. So once you, so in order to then, shifting now to the patient, right, in order to have a great experience for the patient, make clinicians first telehealth confident, define and train on the great workflows to ensure a great experience, conduct telehealth tech checks, and also conduct patient surveys. So I mentioned the tech checks multiple times. You offer that ideally to the patient a few days before the visit so you can recover and maybe reschedule it as an in-person visit. And then provide guidance on all the elements. And then here are all the elements. So you talk about, okay, where are you going to be located? What technology are you using? How are you connected? Cellular? Do you have a data plan? Is your data plan maxed out? When will you be joining? From where? Or actually, how do you join? You click on the link in this text message or in this email. Okay, let's check your audio and video. Let's check your camera angle. Let's check your background. Let's check your lighting. And if you don't want to be overheard, maybe have some headphones on you so that nobody can overhear your conversation, and be mindful that what you say can be overheard by others. So, and that takes can take 10 minutes. If everything goes well, can take longer if people don't know how to install an app or find the link or find their email password, right? But those are the things that clinicians shouldn't be dealing with. That's somebody else in the organization that's not practicing on top of your license. So this is a very key process for really making sure that it's part of the rooming process, if you will, is that onboarding for the first time. Because the goal is that we have engaged and actively participating patients, especially if we're thinking about chronic care management, which a lot of our primary care is about. I find it interesting to look at the terms, how they've evolved over the years, right? In the 90s and before, it was about compliance, right? You had to comply with the orders of the doctor. And then we softened it a little bit and said adherence to this care plan that we agreed on. And then really the new term about 10 to 15 years ago was engagement, right? We need to have patients engaged, and that kind of stuck. The latest one I've heard that I really like is activation, right? We need to go beyond just engagement. We need to give them the tools, the data, the information, the skills to really be activated, to do the lifestyle changes that they need to make to alleviate the underlying chronic conditions, or conversely. So compliance, submitting to a wish, request, or demand; adherence, sticking to a plan; engagement, participation and contribution; and activation, self-motivated, proactive actions to achieve personal goals. The reason why I bring this up is that I think telehealth has this great opportunity to create activated patients, to activate the patients. Because, especially in a rural environment, I don't know, right? What are the statistics for cancellations for a follow-up visit, or where somebody just doesn't find the time to even schedule the first visit because the barriers of an in-person visit are so high, from the transportation cost, or daycare, or childcare, or not quitting a job, but not getting paid for your job. So by having those lower barriers, by making care more accessible through that, or by rolling out a remote physiological monitoring program, and having the patient actually see the effects of, so here's the monitoring nurse calling up Sally on a Monday morning. Said, Sally, I see your blood pressure went up here quite a bit. Oh yeah, my grandson took me to the Chinese buffet over the weekend. See, Sally, that's what happened. We talked about salt intake, right? So, and then it's like, oh yeah. So now the patient is more engaged, is more activated, because she has access. And now next time she takes the blood pressure, she says, oh, it goes down. And then, wow, proud. I didn't eat as much salt, or I slept better, or I exercised more, or walked more, moved more, right? So then they're activated, they're actively engaged in their care. And I think that is really the holy grail of virtual care. Video visits to interact with them, secure messaging to say, hey, how are you doing this week? Is the new medication working for you? Remote physiological monitoring, or all the way to digital therapeutics, right? Having an app that reminds you to meditate, or that reminds you of certain things, or that helps you to deal with your symptoms. That's where really I see the benefit of digital health, to really activate patients and to have them participate in their care. So it offers lower convenience or cost, empowers patients to make the choice, and asynchronous access allows for more frequent interactions, especially in value-based environments. Here are the 7 elements of a successful telehealth program. So if you're looking at a virtual care program and want to look at what are the 7 things we need to really have in good shape, and that's, for example, what we've done for Dell's organization that enabled him to launch so rapidly. First, there's a telehealth policy and some telehealth workflows that need to be identified. Then obviously it's about the telehealth technology. Oftentimes you can use what you have available, but sometimes that technology is not as user-friendly, and you can look at alternatives. We need to have good website manners and virtual exam trainings for the clinicians. You need to define some clinical guidelines that allow you to decide When is virtual care actually good care? Then you need to establish telehealth support, and all of that really needs to be tied together by a telehealth strategy that your executive team is supportive of, to provide the resources and to make sure that telehealth is well supported. The guideline here, how do you actually get clinician engagements? Here's our kind of 6 or 7 step process. You connect with the clinical leaders, the thought leaders, the influencers, the champions. You understand the current services and current telehealth use and analyze it. And then you look at designing the optimized workflows, right? What is not working? What is frustrating to you? And then you start with the optimization there, and then you go back to the 7 fourths and you make sure that you have all those 7 workflows defined. Then you develop the training materials and you train the clinicians on the workflows, on the technology. So here's your project plan to engage clinicians more to roll out excellent virtual care. A reminder again here about the ADCAR model of really looking at making sure you're raising awareness, creating desire, provide the ability, provide the knowledge, and then have a sustainability strategy in mind to provide reinforcement by looking at the data, looking at the utilization. If it drops down, ask why and see if there's anything that can be done to bring satisfaction back up, to bring maybe utilization back up. So there's no magic utilization number of a percentage where it should be at, but if it drops down for no reason, then there's some reason maybe behind it or for no obvious reason. And so yeah, we want to start with the end in mind, and that is really high patient satisfaction, because when we have high patient satisfaction, we have high patient activation, we will see the changes in patients that we want. And we do so by making sure that the clinicians are satisfied through the systems and technologies we put into place, and all is enabled by really a commitment by leadership to embrace virtual care as an alternative care delivery modality that is under the direction of the clinician. It's a clinical tool, not a technology, not a reimbursement stream. So with that, I thank you for sticking around for the last keynote here. I thank the organizers at Thriving Together for putting together an awesome program. I've received some feedback from the vendors. This was one of the best organized conferences as well, and everything worked out. And we all found our way into the breakout session. Thank you for all the engaging conversations that I've had with many of you. Thank you for all the work that you're doing in really bringing virtual care forward in your organizations, in your communities, so that we can enable the delivery of sustainable, extraordinary care. Thank you very much.